Well, hey, everybody. Happy Tuesday. I'm Dr. Roney. Welcome to the Cancer Conversation. I hope you're all doing well. We're going to have a good class tonight. Dr. Ptak and Dr. Connealy are going to be answering questions. It's most of you know, it's Breast Cancer Awareness Month. So a lot of the questions that came in are going to be related to breast cancer. And then if we get time, we'll go into the chat section here in the Q&A session on Zoom, and we'll get to those as well. So we'll do as much as we can. We're going to have these sessions once a month. I think that's going to be really helpful based on feedback that we've had from everybody. So we'll do Q&A once a month. And then in between, we'll do some really good topics, have good speakers, guest note speakers on. And we're trying to get that cadence down and pretty much set that calendar up. But I will tell you, the next one is going to be, I'm not sure if they've announced it yet, but I do want to mention it because I think it's going to be really, really a good cancer conversation. It's going to be with the brother of, if you remember Nightbird, Jane from, I believe, what show was it? Was it America's Got Talent? So she was on there, just absolutely blew everybody away. And she was a patient here. So her brother is going to be on to, they have done a nonprofit and a foundation for her to keep awareness going and so forth. So he's going to be on with Dr. Connealy in a couple of weeks. Really, really good, I think, foundation of what they're trying to do. So I think that's going to be great for everybody to hear. And then tonight, again, Q&A, mostly on breast cancer awareness. There were a lot of questions sent in, and we have printouts of those questions that Dr. Ptak and Dr. Connealy are going to work through, and then we'll get to as many as we can on the Q&A as well. So let me introduce, again, myself, Dr. Roney. If you're new to the Cancer Conversation, we do this every other Tuesday night. And I want to take the opportunity to welcome you. If you've been on before, you know, you're probably tired of seeing me. But welcome back. Before Dr. Ptak and Dr. Connealy come up, I do want to give you an idea of some of the things that we've been doing here, some of the things that, you know, we're trying to really tighten up the systems based on what we're seeing, what we're learning. And I could tell you, you know, it's different today, right? And what I mean by it's different is this world, this cancer world, or this chronic disease world is just different. You know, we're not sure if it's the last couple of years, and we all know what has gone on over the last couple of years. If that's playing a factor, I think the statistics show that it may be, and we lean towards thinking it may be as well. But we're seeing things happen quicker. We're seeing things happen earlier. Dr. Connealy says it all the time that certain cancers have a certain warranty, you know, 50 years, 60 years. Well, we're seeing those earlier, 20 years, 30 years. We're just seeing some really, really crazy things go on. So the point I'll make with that is that we have to then change what we're doing in order to keep up with it. And one of the things that I did want to talk about briefly before Dr. Ptak and Dr. Connealy came on board was how we're kind of modifying and manipulating things. So as you all know, the four pillars that we, if you're new to it, we follow a 4-pillar approach, which is basically a plan. And I personally believe, you've heard me say it a million times if you've been on here, I think a plan is necessary. It can't just be wonky and willy-nilly. There has to be a very, very specific set of details put into place in order to maximize somebody's upside. So the testing is one of our pillars. The starve and kill phase of cancer is another pillar that we follow. And starving meaning using repurposed drugs. I'm simplifying it, but we use that for simplification. Using repurposed drugs like metformin or menbendazole or some of the statins, some of the antibiotics in order to block some of the pathways that feed cancer. And so that starve phase is a big part of our care now. And then the kill phase is going to be chemosurgery, radiation, low dose chemo is what we use here. But for most people, and you probably have heard me say this before, low dose chemo or the kill phase, whether it's low dose chemo, starve, kill, the chemos, the surgery, the radiation, what have you, is kind of a necessity with a lot of cancers. I know people come here because they want the more natural approach, and we respect that totally. But the reality is that a lot of patients are going to need a more aggressive approach based on the aggressiveness of what we're seeing. So, easy point I'll make is if we integrate and we do a little bit of the conventional approach and a lot of the integrative alternative approach, I personally think that's the answer. I think people do really, really well. Now, I'm not saying with every case and every patient, but I think the ones that we see here a lot of times are more stage 3 and stage 4s looking for answers. And I think it's relevant that sometimes the natural approach, I think, kind of is the exception, maybe not the rule. I think there's going to be heavy hitters that are needed at times based on what my eyeballs show me and based on the aggressiveness of what we're seeing. So if we could starve it and we can kill it and use the kills like your chemosurgery, radiation, low dose chemo, and offset it with, I use the term, the other 20 chapters or 19 chapters of this 20 chapter book, like oxygen and alkalization, immune boosting, increasing voltage, right? Getting your vitamin C's and some of your immune boosters going at a pretty aggressive rate. What's going to happen is the body is going to stay strong and healthy while the chemo or low dose chemo is doing its work. So you get the win-win. And I think that's where what we're seeing is working quite well. And I'll use the term layering. Dr. Devlin, who's a consultant with us, who basically with Trish does the fractionated or low dose chemo with the patients, and he's taught us a ton. And there's things that I want to go over briefly to show you, how we're modifying the program and how we're creating more detail within the program to keep up with what we're seeing. Okay, so I'll talk to you about that in just a minute. And then finally, in our 4-pillar approach, the 4th pillar are the causes, right? So again, conventionally, they're going to look at, killing it, cutting it, radiating it, and so forth, which again, I think at times is very necessary. So I don't want to downplay that or put that down at all, because I do think it's necessary. But what they're not going to do, they're not going to look at the causes, right? So the immune system, a hallmark of cancer is a weakened immune system. And then we look at the inflammatory process that happens in the body. And you look at things like toxins and chemicals and heavy metals, and you look at bacteria infections, viral infections, candida or yeast overgrowth. You look at parasites, mycotoxins, another fungal infection. And you realize that these things are now a part of our environment, and it's fairly consistent. And if they're in our body, the immune system is going to constantly try to react to those toxins or to those chemicals or to those infections, creating inflammation. The inflammatory process then creates more and more what they call free radicals. And these free radicals start to damage the cell. And to keep it simple, that's the lineage where we have potential antigens or foreign invaders, inflammation, free radicals, damage to the cell. And when those cells are damaged, especially the DNA and the genomes, when they're damaged, they don't work well. And what they're supposed to do is take a damaged or old cell through cell death. But then because the DNA and the genomes get damaged, those cells replicate out of control instead of going through cell death called apoptosis. That's cancer. But it stems from inflammation, free radicals. It stems from causes. So to leave that out of the equation, I think is a huge mistake. And I think it's something that within a plan, you should always consider looking at the causes. If you have active cancer, getting rid of the causes is going to allow your immune system to work better. It's going to allow, to take away the reasons why that immune system may be overacting and creating those free radicals. So it'll help you heal short term, but it'll certainly prevent reoccurrence long term. And that's, again, a staple in our philosophy here of treating. So those are the 4 pillars. Now, having said that, what I want to get to is some of the things that, somebody like Dr. Devlin, who's an expert over the years, 20 some years of experience in this integrative oncology world. And what he's done for us and has helped us with is being able to look at the charts and making sure that we're following surveillance the right way, as an example. So what Dr. Devlin talks about is when you open a chart, you want to make sure that the person, even if they're NED, which means no evidence of disease, is still following a protocol of follow-up that can catch things if they reoccur, can catch them very early on in the process. And I think what he's done and what we went over with the doctors as an example today in one of our meetings, he went over the cadence and the frequency of follow-up, not just follow-up consults, but I have in front of me, following up on tests like the Guardant test or the Fulgent test or the RGCC or some of those circulating tumor cell or liquid biopsy tests, right? So that in his opinion, for many people, it should be about 90 days. And then the cancer markers, whether it's CA125, 2729, 15.3, CEA, PSAs, et cetera. These are cancer tumor markers. He does them every 6 weeks, right, to follow up with a patient. And then some of your complete blood counts and your metabolic panels, iron, ferritin, CRP, things like that are done as needed. That could be every week if you're going through chemo or low dose chemo, or it could be monthly. It just depends. The doctor basically decides that. And then how often do we do imaging? Well, he likes to do it about every 90 days. And again, it can be case specific, but the point I'm making is what he feels like has helped him the most is create a cadence of repetition as it relates to labs and studies and diagnostic imaging and things like that. That way, we're always on top of the ball, right? We're always on top of the game. So again, if something does pop up, we're able to get on it earlier. Now, I could tell you, I don't know that we've done it that routinely before, but again, to his point, he said, if we can get a reoccurrence early enough, we can get on it early and we have a much better chance again of a better outcome, reduce the risk, lower the risk, increase the upside. And so the surveillance part of it is something that we're doing much better at and much more frequently. Not so much better, we're just doing it more frequently because of the environment that we're seeing today, because of the cancers and how quick we see them kind of moving. Who knows why, right? We talked about potentially the last couple of years and that playing a factor, we don't know, but it's just we're reacting to what we're seeing. And having people like Dr. Devlin here is really good with his experience to show us what he's learned over the years. So I feel like we're constantly tightening up our systems to give better and better care. And I wanted to share that with you. It's just one thing that we're doing, but we're constantly reevaluating our process and our systems to make sure that we're not dropping balls and we're dotting I's and crossing T's. And I think that's something that if you're with another practitioner, cadences like that are maybe something that you could talk to them about. So I did want to share. So anyway, that's just a quick update on some things, but I'll bring Dr. Ptak in. She just got done with her patients.
Climbing through here.
Yeah, she's climbing through. There you go, my dear. All right. So, and then as we talked about, Dr. Connealy will be up in a short time as well. And then I'll let her have this seat and then I'll make an exit somehow. I'll get around here somehow. But yeah, so welcome, Dr. Ptak.
Thanks for having me.
Yeah, absolutely. Thanks for being here. So I was explaining to the audience, because it's Breast Cancer Awareness Month, a lot of the questions will center around breast cancer. However, we'll do that. You and Dr. Connealy will do that, but then there's always the Q&As on here. If we have time, we'll get to those as best we can. And Dr. Ptak and I were talking about this earlier. Sometimes we get very specific cases and very specific questions regarding the cases. it's a little bit hard. I do want to preface this when we do these Q&As. It's a little bit hard to get into giving advice when we don't have all the info. And so if you have a question, Dr. Ptak, Dr. Connealy will try to answer it as best they can with the information they have. But if they feel like they can't do it due diligence or justice, they'll let you know. And then that's, unfortunately, that's whether it's somewhere else or here, a full workup consult, looking at medical records, things like that, which sometimes to give the right advice is just kind of a necessity. So fair. So I just wanted to preface that because it gets hard sometimes to answer some of these specific questions. All right. So we'll start. Okay.
Okay.
Now, do you have anything you would like to talk to the audience about prior to? Is there
Not prior to. I think we can just jump in
jump in. All right.
Yeah.
Fair. So I'm the talker, so I always have stuff to say. So I figured I'd give everybody else the opportunity as well. So, okay. So one of the first questions that always comes up is, what do we do to prevent cancer? So let's talk about that a little bit. I'll let you kind of take over. I might fill in a blank here and there, but what do you think?
Well, very broad question. And it comes down a little bit to type of cancer, because every kind of cancer is going to have different inherent risks that might be a fuel to it. In general, when we're thinking about what cancer is and why it develops, it comes down to cells replicating and there being errors in those replication. So part of that comes from natural aging. As we get older and we have more cells replicating over our lifetime, there's just more inherent risk for there to be errors. So age is a risk factor.
Sure.
But then what are variables that influence the success of my cell replicating? Every time a cell replicates, 9 billion base pairs have to make an exact copy. And we have a lot of amazing checks and balances that try to correct errors that happen. On average, with every replication, we estimate that there's about 3 errors. And so things that are going to increase replication errors are toxins, things like alcohol, chemicals off-gassing from car exhaust, things that are in the manufacturing industry, heavy metals, things like that. Those not only damage DNA, but also impact the enzyme function that's meant to repair errors in the DNA replication.
Yep.
So avoiding toxins and working on, we use the word detox kind of loosely.
Routine, yeah, right, exactly.
It's too general of a term. We're talking about sweating, having regular bowel movements, drinking enough water to flush things out of the kidney. Yep. We're talking about your liver having enough nutrients to process toxins, break down food, repair. So those are some of the things that go into detox. It's not just like juice cleanse.
Right. It's actually supporting what they call phase 1, phase 2 detoxification pathways. It's limiting the amount of toxins that go into the body, and that's a whole other discussion.
And then there's sleep.
Yeah.
Most of the repair that happens to tissues in your body comes from getting enough sleep. And then fasting too. Fasting is when your body gets a break from breaking down food and things that you're taking in. I don't think we think about it very often because food is so calming and, lets us feel like we're at ease. But eating is a very stressful thing that our body has to do. Has to break down the food, has to treat any parasites and chemicals that are coming in. The immune system has to triage everything. So, of course, eating is crucial.
Yeah.
Having fasting periods and, maybe do a couple of days of fasting a year, that kind of thing can have a profound impact.
And they're proving that it has a profound impact on resetting the immune system, right? It has a profound impact on your blood sugar stabilization, on your just cellular function in general, stimulating certain adversity genes, right? So there's just huge impact. So to recap, the simple, there's simplicity to this, right? Which you've heard for years, which is, okay, good eating, good clean eating. So like Dr. Ptak said, if you're eating clean, low inflammatory, I like to do a low inflammatory diet. And if you're doing that consistently, you're keeping your fats and your proteins, I think, somewhat dominant versus, say, the carbohydrates. Your carbohydrates, you're being carb conscious, generally speaking, organic vegetables, some low glycemic fruits. I'm okay even personally with adding in some complex carbs here and there, like sweet potatoes and maybe quinoa and things like that. I think they're very helpful.
High in minerals.
Yeah, high, but they're clean. They call it real food. If I'm on a deserted island, what could I eat? Right? I could pick it, chase it. Now, again, there's going to be probably pros and cons of meat versus, a more vegetable and vegetarian type of diet. Totally understand that. But in general, if we're doing meats, we want to do things like pasture raised, pasture finished, very clean, etc. Right? So that general concept of eat real food and be conscious of how much you're eating, because then if it's a decent portion, smaller portion, I would say overall, and it's anti-inflammatory, to your point, it's just not as stressful to the body. Fair?
Yeah.
So that's a biggie. And then you're fasting, like Dr. Ptak said, of course, exercise, especially working in that high intensity exercise that has a lot of value. It doesn't have to be a long time, but it could be, shorter impact, 10, 15 minutes, higher intensity is does wonders for the body, quite honestly. And then sleep and water intake and all those things that you know about. But to your point, those toxins and chemicals and mycotoxins from molds and things like that are everywhere today.
And unfortunately, it's more of a problem than we think. It's like, okay, well, yeah, I drink filtered water, or, I don't have any metal fillings in my mouth. But unfortunately, there's heavy metals in the fast fashion clothes, things that are very quickly manufactured.
Skincare products, hair products.
Have metal. Yeah, it's really
everywhere.
all over the place. And so people are shocked when we do toxin testing on them, and they're like, I do everything. And it's like there's some exposure somewhere that you have to find. So
yeah, and then you get into, and this isn't, I don't want to get down the rabbit hole, but then you get into how your genes, the epigenetic factors, which are how your genes are expressing, that could be if affecting your detox pathways and affecting how you subdue inflammation, if you will. So whole other story. But getting back to the prevention, is the prevention and the cure are very similar, right? As far as when we have somebody that has active cancer, we take them through, and this is pillar 4, right? The pillar 4 is finding the causes, finding the fuels that are instigating the inflammatory fire, right? And those are all those antigens that we talked about, are foreign invaders, bacteria, viruses, parasites, candidas, yeast overgrowth, fungal infections like mycotoxins or heavy metals or non-metal toxins. We need to definitely look into those if you're trying to prevent cancer. And even personally, I'm sure, Dr. Ptak, I tell everybody, I was big for years on my exercise and my diet and my supplements. And I'm like, okay, I'm doing enough. But then you're here and you're going, okay, I'm definitely not doing enough. I have to go into that deeper dive, because we're seeing patient after patient come back with a lot of these things going on. It's there. Some people's body does better than others handling it. But at the end of the day, I think the deeper dive is worth the investment personally, based on what we're seeing today. Would you agree? Yeah, getting into all those different things. So hopefully that was somewhat helpful with how to prevent cancer. I think there's a lot more to it, but that gives you a good insight and a good start.
I think people overlook the basics.
It definitely.
It's like they want, what's the magic pill, or the thing that if I just do that, I won't ever get it.
Yeah.
And it's really like, you have to be sleeping enough. You have to be exercising enough. You have to have muscle mass, and,
putting clean stuff in the body. And I mean, it's kind of that labor. It's laborious. However, I think it's totally worth it. It becomes habitual. And then what happens, which is great, you start to feel so much better when you do it. And you're like, okay, now you're on this straight and narrow path. And you're going, okay, I think I've got a handle on it. And then you get off the path, say over a weekend, right? Have a fun weekend, if you will. You're like, ooh, that hurt. So it kind of brings you back to reality too, which is great. So yeah, I think that's a good general. I mean, there's a lot to it, but I think that was a good answer. So the next question that comes up, the timeline to cancer is 8 to 10 years. Oh,
Latest test.
oh, sorry. Yeah, I missed that. Oh, what are some of the latest tests that you can take to determine if you have cancer? It's a great one.
Yeah, I think the standard right now is what are the most common kinds of cancers and how can we screen those?
Mm-hmm.
So that's where we get mammograms, that's where we get checking your PSA for prostate cancer, getting your colonoscopy, etc. Those are done in a cadence that tries to make sure it's done frequently enough that you catch it.
Mm-hmm.
Um, without overreacting. If there's something that's slightly off, that's just going to go back to normal on its own. Unfortunately, even though those are the most common kinds of cancers, there's other kinds that just get missed all the time.
Yeah.
And they can be some of the more aggressive kinds like pancreatic and that one comes, top of mind. Now they've got the whole body MRIs like Prenuvo.
Mm-hmm.
And I've had a lot of patients coming in and bringing that in. They elect to do the screening on their own. It's where you get a whole body MRI without any contrast. So no radiation exposure because MRI doesn't have the radiation, and then no heavy metal exposure from the contrast.
Right.
And what I'm seeing with that is it has caught
Yeah.
abnormalities. And there's a lot of incidental findings too. So maybe cysts on the kidney or cysts in
Mm-hmm.
the liver or, a little nodule on the thyroid. And it's up to the primary care doctor or us here at the center to go through every single line of results with you and make sure there's a plan to follow up on it. At the very least, repeating imaging in 6 to 12 months just to make sure things are stable. But getting imaging can be great.
Yeah.
It's not perfect because usually by the time something's visible on imaging, there's more of a
30%.
problem.
Yeah, there's usually a big percentage of change to show up on there.
And so, yeah, I think the future is going to be in testing circulating tumor DNA. Actually, I
Mm-hmm.
know City of Hope down the street from us here is going to be doing a clinical trial and looking for circulating tumor DNA as a screen some of the preliminary research that's being done is showing that the cancers they're better able to detect are the ones that we don't have regular screens for. So pancreatic, bladder, lung, etc. So that's kind of interesting.
Yeah, no, I think it's great.
The researcher's name is Dr. Tomasetti, if you want to look it up. But yeah, it's keeping up with your screens, working on all the risk factors,
Mm-hmm.
and then imaging anything that feels off in your body, getting imaging and following up on it.
Starting with, say, an ultrasound, it's pretty low invasive, and then working your way up to CAT scans or MRIs, or, if it had to be, if there is active cancer, the PET and CTs and so forth. But yeah, I think the imaging is big. Some of the labs that we do here, and I'll give you an example. Today, I had a patient that his PSA, which is a prostate specific antigen, one of the tumor markers for the prostate, went up to about a 6, which is a little bit high, but around 4 is the upper end. It went up to a 6. So I talked to Dr. Connealy about it, and she said, hey, we definitely need to do a workup. So things like nagalase and PHI and D-dimer, these are enzymes that cancer cells secrete, and possibly if they're elevated could indicate things. So Dr. Ptak will tell you that not one test is everything, but you want to start painting a picture. So if we did with this patient, if we did say the RGCC and looked at the circulating tumor cells, right? And then we did nagalase, maybe PHI, we did D-dimer, we did some more of his cancer tumor markers.
And he should do ExoDX.
Which is
there's a test we have for prostate. It's called ExoDX, and it's FDA approved for if your PSA is between 2 and 10 and you're over the age of 50. And it's a urine test. It doesn't need any kind of prostate stimulation or anything beforehand. What they're measuring in the urine is basically exosomes, which is like the waste material of prostate cells, and they're looking for genetic markers in it that indicate risk of there being a high grade malignancy.
Okay.
So
ExoDX.
with prostate in particular, there's a lot of PSAs between 2 and 4 and 6, and it's like it can be inflammation, it could be infection, it could be, you know, all sorts. It could be you rode your bike too close to the PSA being done. And so the ExoDX helps to clear away some of those other factors and look for the genetic markers that would indicate high grade. By high grade, I mean a low grade would be a Gleason score 6, where the protocol, if things are just in the prostate, you might just watch and wait, not necessarily need to do any active treatment. If there's high grade, it's much more likely to spread, grow faster, cause, you know, compromise, in which case you'd want to do more decisive action. So the ExoDX helps us differentiate, do I need to go to biopsy right away? Can I wait and continue monitoring? And there's different tests like that for depending on different tissues in the body. That's the one for prostate.
Yeah, no, it's great. I'll definitely, we'll definitely do that on them. I think that's a good one.
It's new to us in the last 6 months, but I've been happy. Good, I've been happy with the results so far.
See, I learned just like you all learned. That's great. So some of those tests, we have them, and it's designed to paint a picture that sometimes I was telling this gentleman, I said, sometimes we look at everything like, it looks good. We do an ultrasound, things are clean, testing is clean. We know we just want to monitor that PSA. And then other times, you know, something like that sparks us to do some of these tests and imaging. And it's like, ooh, something's going on. You know, we did that with a patient that you saw a couple of weeks ago that came back with a little something on her pancreas. So we're working through that process now. So again, the right test can paint a picture, and it's it's not one per se, but it's a conglomeration of several or more that can paint that picture for you. And that's, you know, from a early, you know, you can catch it early if you do that.
And another test that I just learned about today, Dr. Connealy just brought it to my attention, and it's new, so I need to learn about it. Yeah. Did you talk about it?
No, I didn't.
It's called QT, the letters QT. And it's a type of ultrasound that paints a very high resolution picture of, in theory, any tissue in the body. But right now, what they're approving it for is breast screening. And where it's particularly helpful is in the case of dense breasts, which I can't remember the last mammogram I reviewed that didn't have dense breasts in the title. And what that means is that the tissue itself is denser, and it makes it very difficult for mammogram to see through and differentiate healthy tissue from unhealthy tissue. So a lot of things can go missed if there's dense breast and all you're doing is mammograms. It always needs to be followed up with an ultrasound. And with the QT testing, what they're proposing is that you wouldn't even need the MRI because it's 40 times apparently more resolute than an MRI anyway. So that's kind of new. We're going to be researching that, and you should look into it.
In water too, did I read?
Yeah, the ultrasound waves are delivered through water. Your tissue is water-based. And so when you go get an ultrasound regularly, they have to put the little ultrasound head on the
to create the
fluid,
conduit,
so you can have the conductance of the sound waves through. But if the breasts are submerged in water, you're kind of laying on a table, it looks like from the images I've seen, and with the breasts in water, the sound waves can kind of transfer through that way.
Easier.
It's kind of interesting.
Yeah, no, I love it.
But in theory, that technology they're hoping to adapt to, you know, do whole body screening. So we're on the cutting edge, folks.
Good stuff. Okay, so hopefully that took care of you. Feel comfortable with that? Okay. So the next question, the timeline to cancer is 8 to 10 years. What is the timeline from a rogue cell to a noticeable or detectable cancer diagnosis? It's a tough one.
Yeah. A kind of political answer, which I don't know how else to answer it in this case, is how are you measuring when a rogue cell develops, when that becomes a full-on cancer? But in general, the energetic imbalances, the insult to the tissue from an injury or from low oxygen hypoxia, from nutrient imbalances, those all start to happen years before. And then by the time a rogue cell develops, now it's going to be growing and dividing and creating a colony. Depending on,
it's a good question to hand off. It's a good segue. Connealy. I'm gonna let Doc come in.
Hi.
Here, my dear.
Hello.
Hi.
Let me have your little thing. Thank you so
I thought she was going to give me a hug, but she was taking my microphone. Just kidding.
Hi, everyone. Sorry, we had a few complicated. Oh, okay. We had a few complicated patients, which happens every day here. So it's a never dull moment. So what was the latest?
What we're talking about, we kind of went through cancer prevention and, lifestyle factors. We went through testing, talked about Pernuvo and tumor markers, and we talked about the QT a little bit. Now we're into timeline to cancer. And I was just painting a picture of the kinds of imbalances that would cause damage to cells in the tissue, from physical trauma to the area, to viruses, to nutrient imbalances, to hypoxia or low oxygen. Mm-hmm. When a rogue cell develops, that means a cell that's going to grow and divide without any checks and balances, and it can create a colony of abnormal cells. That point to diagnosis is different depending on how aggressive the cell is. You can have something high grade, which means faster replicating, maybe has a higher what's called Ki-67 or proliferation rate. Those things can show up very quickly, versus a low grade tumor, which is generally slower. And so it really just comes down to when you become symptomatic from it. Is it something you feel in your breast? Is it something that's causing, some disturbance in your function, like blood in the stool or colorectal, something like that?
Yeah, but preferably, at our clinic, we really strive for, human optimization and prevention. Mm-hmm. But of course, we do have patients come here, after the fact, or again, like you said, they might have pain or bleeding or, some other symptom. But, in this day and time, 2023, we all need to think about prevention and human optimization all the time, no matter what. And if you've been diagnosed with cancer, you should be spending everything on how not to get cancer again. Mm-hmm. So, and that's what we strive for. But, at the same time, we're as good as you are, and you're as good as we are. So it's a very important partner relationship. Mm-hmm. And you have to go home and do it.
The homework.
Yes. Yeah. And you got to go home and do it. And we do too. And we do too. We're living it too. So mm-hmm. It's not like we're exempt, because we got to do our own self-care. Mm-hmm.
So the next question comes to, is there a common misconception among individuals in the population that cancer occurs overnight, like out of the blue? And then why is it that doctors aren't talking more about circulating tumor cells?
Well, that's a very good question. So cancer doesn't happen overnight. In fact, I was listening to a guy that I know, and I've followed him for a long time because he was director of Cochrane Collaboration Group, which is the largest, it's a group international that actually analyzes studies from all over the world and comes up with the right conclusions.
They basically research the research,
right,
and say what it all cumulatively says.
Right. Mm-hmm. So anyway, and he, I was listening to him this morning because he wrote a book called Mammography, Truth, Lies, and Controversy. So if you want to know about that, you can read that book on your own. But the doctors were talking about that cancer starts, more than 10 years. So, but what I have learned over the years from my mentors and everything that I've read, that cancer is about a 10-year disease, unless you're like in Chernobyl, where you're exposed to radiation or some other serious chemical exposure. And so cancer may come earlier. But that's why I always say we have years of opportunity to prevent cancer. And so we know by looking at the blood work and all the testing that we do, Dr. Ptak mentioned the whole body MRIs, the tumor markers, the circulating tumor cells, and everything. Now, the circulating tumor cells are relatively new information, but not that new, because I know that there's 5 articles a day on PubMed on circulating tumor cells, but it's not still mainstream medicine yet. Now it is for us, and we have multiple tests. There's multiple tests that we use to detect circulating tumor cells. But again, it's just, it takes about, usually by the time something's in the literature, it takes about 20 years really to get into formidable practice. Mm-hmm. So I would like it, we'd all like it to be sooner, but you guys know us and you can share the word and share all these cancer conversation with your friends and family and significant others so they can learn with you. So anything else to add, Dr. Ptak?
I guess I'd say from a research perspective too, circulating tumor cells are difficult to isolate and test for. There's a lot of companies that have failed to find sophisticated apparatuses that can really isolate them and measure them. And they're being used more in a research capacity versus like most medical doctors that I've talked to about them might know them from research, but not necessarily think of them as a practical thing for because of the limitations Dr. Connealy mentioned. So one day.
Yeah, one day. So
okay, so now we're getting into just the stigma around cancer, why it's important for cancer patients to not give up hope, and talking about the mental state and mindset around having a diagnosis and going through the day-to-day of, healing from this.
Right. Well, I think that's the biggest thing that we offer is hope, because in our clinic that we're all of us doctors are constantly trying to understand, research, learn, go to courses, the latest, greatest. We connect with all kinds of other people around, and that's been developed because of years and years of relationships. And so typically patients are said, they're given, a bad prognosis. But usually all of us can try to create a plan. That's why it's more important to come to us in the beginning before you have some other, more devastating situation. And so patients, doctors, when you go to the regular doctors, they don't give you like all the things that you should be doing. Patients may be a candidate for surgery, chemo, and radiation or medicines, but you've got to take care of the garden and the terrain that the cancer came in. And that's what the conventional doctors don't do. And so we're trying to take care of you and protect you while you're getting a biopsy, a surgery. So we have a biopsy protocol, a surgery protocol, a chemo protocol, and a radiation protocol, and then the protocol after all of that, because you've got to clean up for about a year from all the surgery, chemo, and radiation. And so the conventional world just isn't quite there yet. They will be, because patients are learning from all the different health podcasts there are, and they're reading and learning all the expansive information that is becoming more and more available.
And then as far as not giving up hope goes, I think the power of the mind is so understated in medicine. You have to be talking to yourself like the miracle that you are, and your cells listen to that. There's kind of a silly study that I like to reference about college students that were given milkshakes. Have you heard of this one?
No.
They sat a bunch of college students down and gave all of them the same exact milkshake, but they told half the students that it was called the indulgence shake, and it was high fat and high calorie, and blood sugar is going to go crazy and you feel good and tired afterwards. And then the other one was the weight loss shake, high protein, spinach, vitamins, and they measured their blood sugar for minutes to hours afterwards. And the students that thought of it as something that was going to spike their blood sugar had drastically different blood sugar levels than the students that thought it was just going to be, for weight loss and healthy metabolism. And so your body is going to listen to everything you're telling it about what you're doing. And that's super important in this whole journey. And it's a super important skill to develop for every aspect of life.
Right. On a day-to-day living, you have to have, that's why we give all of our patients healing affirmations, because it helps them program their brain every day, because we have about 25,000 thoughts a day, and 90% probably 90% are subconscious, or we don't even know that there's a record playing that you're not even aware of. And so if we're intentional with how we think every day, and all of us, no matter how old you are, have a history, and some of the history is good and some of the history is not good. And so we've got to now become super intentional with our thinking process by being very aware of conscious intentions every day. And that's why we do EVOCs on all of our patients. All of our patients, we recommend and have them do EVOCs. And if they don't want to do EVOCs, we have to try to come up with something else. But there's probably, like Dr. Ptak said, there's probably the mind is really your hero of the body and the architect of the cells, what they're going to do and what they're not going to do for you. Because in medicine, we have something called the placebo effect and the nocebo effect. The placebo effect is you take it, like she was just saying about the milkshakes, you take it and it's going to, work for you. Or like, I know I'm taking this pill and it's going to work, but the placebo effect in many things is like 50% or more. Mm-hmm. And the nocebo effect, if you don't think it's going to work for you, like I have patients that say, well, Dr. Connealy, I don't want to do radiation. I know it's not going to be good for you. Well, it's probably not going to be good, work for her, because she thinks that it's going to have a negative connotation for her. So I think that we just need to, there's a great book that I've learned the most about this is, and I want to have him for Cancer Conversation. And you may have heard of him. His name is Bruce Lipton. And he wrote the book Biology of Belief many years ago, and he taught at medical school. And so I would encourage all of you to listen to a YouTube of his so you understand how the mind does control the cells. And I always say that your cells are constantly listening to your thoughts. So be very mindful every single day on a regular basis how you're thinking, and try to turn negative things into positive affirmations, because that is really the most successful way to live. So,
and that brings us to your support system and the people that are immediately around you. What do you say to patients that are having, or people that are having challenges with their family members accepting an alternative way of going about this?
Right. It's very important. Like this week, I had a patient who came to see me and from Texas, and she was a young lady, 36 years of age. And she came here with her mother. And so she came to get a workup because she had told us that she was diagnosed with stage 2 breast cancer. And she said she was a year and a half or 2 years in remission. And so she wanted to now, really see what she should be doing. And so when we did her blood test, we noticed her tumor markers were high. It was the first time we saw her. And so I said, oh, your tumor markers are high. We need to do some more testing, and you probably need to get a PET scan. So they had stopped doing tumor markers 2 years ago. And so now she doesn't have stage 2. She has stage 4 breast cancer. And so all of her family, friends, 10 people were on the Zoom call with me this week. And I say, well, one thing you have is an amazing support system. Mm-hmm. So it is very important. The people you have are loving and supportive of you. I always ask, is your husband supportive of you? Is your children supportive of you doing, this? And, a lot of what we do is conventional medicine and or direction. And then, but we also do all the other part that is unconventional, but it has lots of, evidence-based medicine behind it. And it's just good practical things that we all should be following in some form or fashion.
And when we're challenged by family members that might not understand where we're coming from, it's, more of a burden on you, but there has to be some boundary setting. And usually when there's resistance from a family member, it's fear that you're going to forego the treatment that you need. And really what might be needed is the education. So bring those people with you to your appointments. Give them Dr. Connealy's book so they can start getting educated on it, and then set a boundary. I hear you saying that you're not as supportive of me taking this journey. I know that it's coming from love, possibly from fear. I need to do this to have congruence with my heart, mind, and spirit. And I hope that you'll support me. And, setting up boundaries if needed, if it's going to lead to some problems in your relationship, because you need to be surrounded by light and healing energy all the time.
That's right.
To feed that placebo, or, what we believe is the positive energy you need to heal.
Right. Mm-hmm. Very good.
Okay, so now we're getting into some specifics here about surgery. Have a lump, in this case, it's a breast lump. How do you prepare for surgery? And how do you, come off of the surgery?
Right. Well, surgery is a very injurious immunosuppressive process. And I've had surgery, so I know all about that. And so we recommend the patients, one, mentally, emotionally get ready for the surgery. Number one, because it's very important to program yourself how great the surgery is going to be and how good the outcome is going to be. And then obviously following great lifestyle, adequate sleep, water, good eating, no sugar, get off any kind of processed junk foods. We don't recommend that at all. Anyway, getting adequate exercise, getting all the nutrients that you need, making sure you have sufficient nutrients so that your body can, respond and heal from the surgery. And then we always give a certain protocol. We give Tagamet to all of our patients before a biopsy and before surgery, and 1 month afterwards. And then we always have our patients do IV vitamin C before, maybe 1 to 2 sessions with hyperbaric, because hyperbaric oxygen cancer cells, thrive in a low oxygen environment, but also hyperbaric really accelerates healing. So we have them do IV vitamin C and hyperbaric before and after surgeries, along with modified citrus pectin, which is the outside of lemons, limes, grapefruits. So we had a cancer conversation on that before. So that has very strong studies about preventing metastasis and inflammation, and it's great for detoxification also. So we have the patients take that also. We always give them the oral vitamin C, and we'll customize a protocol depending on the patient also, because everybody doesn't have the same supplements maybe, and different things that we may have to fix. Like if you have high sugar levels, that's going to be something, because the higher your sugar, your poorer outcome for healing from surgery. So again, it's very, very important to be in the most optimal state if you're going to have surgery, and the aftercare of the surgery. Like, for example, my patient who just had surgery for triple negative breast cancer is a patient Dr. Ptak and I see. And fortunately, she had a good surgery with absolutely no cancer in her pathology. And but she developed a cellulitis, and she felt that the doctor wasn't taking care of her properly. And so she went to a new doctor who did take good care of her and actually knows us very well. And so now she's getting really good care, but she had to take a lot of IV antibiotics in the hospital and at home through an IV. So now what does she have to do? She has to rebuild her gut, because her gut's been destroyed. Plus, she was telling me that the surgery, she's only 40, but the surgery and the whole process of being hospitalized has just worn her out. So now she's got to recover not only from surgery, but cellulitis and taking, multiple very powerful antibiotics. So she's going to need, and I tell people it takes about a year to get over a surgery like that.
And there's the gut microbiome, like you mentioned, but also the candida.
Right.
When you take antibiotics, your suppressing the microbiome, and that allows opportunistic infections to grow like Candida, which produce acidity and acetaldehyde and other things that are dampening to our immune system and our overall metabolism and function. So it's not so simple.
Right. Nothing is so simple. And that's the sad part, because the conventional system doesn't think about all of those ramifications and all the things that we need to fix after you have something like that.
Mm-hmm. So it's Breast Cancer Awareness Month. So can we talk a little bit about breast cancer screening? When should you start getting screened? What are the best screens, risks, and limitations and benefits of different screening options?
Right. Well, now that we're seeing so many young people with breast cancer, when I say young, 25, 30, 35-year-olds, 40-year-olds, because there's no screening for women really until 40. Mm-hmm. And so mammograms are not good screening for younger patients. It's not a very effective screening tool. So I would recommend at this point in time a thermogram and or ultrasound, probably both. And at least for breast cancer prevention. And so that's what we have available now. I know Dr. Ptak mentioned some new
the
QT test that's going to be available. And we looked it up today, it is available in some places already. So Los Angeles. So that kind of screening. So, and then there are things that we do here that the things that we do here to ensure good breast health. Mm-hmm. And so.
Yeah, so there's pros and cons to all the different kinds of breast screening. Like Dr. Connealy mentioned, mammogram may not be as helpful in younger people, but also not helpful if there's dense breasts. So that's where ultrasound comes into play. Mammogram can maybe see calcifications best. So it is, worth considering doing periodically.
After 40.
After 40. Ultrasound can see lumps and bumps and cysts very well. Thermogram takes a picture of heat and vascularity. So in theory, if there's a cancer abnormality in the breast, it would have increased vascularity and increased heat from how fast the metabolism is going. There are other things that can cause those imbalances, like estrogen dominance with or without progesterone deficiency. Sometimes iodine deficiency, poor circulation, maybe you're based on what kind of work you do, you're hunched over, and so the circulation or strength is off in the breast. So thermogram's not 100%. It's not going to tell you exactly what's going on, but it's a good screen.
Adjunctive tool.
And if the imbalance that you're seeing on the thermogram is caused by hormone imbalance or nutrient deficiencies or poor circulation, those are risk factors for cancer. So you need to know if that imbalance is there so you can treat it early. Right. And then ultrasound helps to complete the picture.
Right.
And then MRI, sometimes, that can get ordered if you have a stronger family history of breast cancer. There's inconclusive findings on other types of imaging. It's a very long study. It takes 20, how long does the breast one take for MRI? Several minutes to hour.
Yeah,
long.
Exactly.
And they have to use a contrast dye, which is a heavy metal, but sometimes if the other studies are inconclusive, you need to go for that. So usually one test alone is not enough. Screening early if you have a concern or family history, I think is recommended. Typically, I recommend that patients have some kind of awareness of what their breast tissue feels like. It's not uncommon if there's hormone imbalances for cysts to come and go. Usually those fluctuate with menstruation and where you're at in your menstrual cycle. Usually they're tender. There's other hormone-related symptoms at the same time. So if you feel a bump that's not changing or it's getting bigger over time, non-tender, feeling kind of fixed, I would talk to your doctor about it and get some screening done.
Yeah, it's very good.
Okay, so if you were just newly diagnosed with breast cancer, either you have a newly found something on imaging or you just got a biopsy, what's the next step?
Right. So first of all, we'd like to have the patient before they even have a biopsy, because a biopsy is, again, intrusive, invasive procedure. So we like to prepare the whole body for that, of the things that we talked about earlier, the Tagamet, the modified citrus pectin, et cetera. So vitamin C. So that would be our ideal situation. And then, like Dr. Ptak mentioned, typically if we were to see a lump on an imaging like ultrasound, we would automatically order an MRI, because that will give us a better picture of the pathology, and we also will give us a good assessment of the lymph nodes. And so the lymph nodes under the arms, because it changes the direction. We would do very comprehensive blood testing. If you read my book, The Cancer Revolution, I talk about all the blood testing that we do, but we do much more blood testing than what a conventional doctor does. And so, and patients always comment that, oh my gosh, my doctor never checked all these things. So we do, because everything gives us a clue of what we need to do and how to best take care of you. And then we will, once they do the biopsy, you will get the results. And we always like to include an oncologist for your understanding of what's going on, so you know all the options.
That being said, one of the things I hear all the time is, no one went over my pathology with me. I don't know what any of this means. So it's really important that you sit down with us or your doctor, who can read through line by line and tell you, this is what this means, this is how big it is, this makes it more or less aggressive, so that when you're having to face a decision about treatment, you're going in fully informed. Maybe there's evidence that it's not particularly aggressive and you have a couple weeks to think more about what your options are. Or there's features that make it highly aggressive, like higher grade, or there's evidence that it's in a lymph node already, things like that, that we have to be a little faster with. So really going through your pathology is important too.
Right.
And getting complete imaging. Usually if there's an abnormality in the breast, they look at in the armpit too. If there's nothing in the armpit, they skip the evaluation of the rest of the body. But every once in a while, it can skip the lymph nodes and go somewhere else. So
right.
Making sure we've done enough imaging to get a full picture and scope is very important too.
Right, because that's a very good point, because about a year ago, I had a patient come to me for a second opinion, and she had not even had an MRI. She had ultrasound, and it showed a lump in the breast and in the lymph glands. And so I said, well, have they done an MRI? No, not yet. I said, okay. I said, I think we should do a PET scan. And she goes, oh, no, I don't want to do a PET scan. I said, okay, well, let's do a whole body MRI. And so we did the whole body MRI, and she had it everywhere. So, not that we order a PET scan on every person. It just, again, it's decided on an individual basis. But today, because more and more people are hearing about whole body MRIs, they're choosing, for peace of mind, to say, okay, let me make sure it's not somewhere else. And so, again, we're trying to be as complete as possible, because, these PET scans and CT scans don't come without harm. So we have to also protect you from the radiation damage from CAT scans and PET scans. So again, we'll decide on what's the best imaging based upon what we see in the data and the imaging and everything. So, and then, once the patient understands what's going on
and has had multiple opinions.
Right, exactly. Very good point. So, because you want to understand your condition, so you know what direction you should do. And this cancer started 10 years ago plus. So it didn't just happen. So a lot of people think, oh my God, I could get this out right now and I need to take care of this. And I always tell patients, no, this didn't happen overnight. Let's take a very methodical approach, look at all aspects, understand, the dynamics going on here, and then come up with the best plan that you feel most comfortable with, knowing the proper information. And so, again, depending on, a patient's surgery, if it's a lumpectomy, they always do a sentinel node biopsy also to make sure it's not in the lymph nodes, even though imaging may look good. They will always do that. And then if it's in the lymph nodes, that usually is a different plan. So chemotherapy is sometimes chosen depending on all the tests. They do oncotype and mammoprint to decide if chemotherapy is necessary. And it also depends on the scope of the breast cancer. Is it just in the breast? What size is it? Is it in the lymph node? Is it in other organs? So a whole plan will be devised once we know the scope of the disease.
And that brings us to some of the newer testing we have this year, like Guardant and Signatera, that look for minimal residual disease.
So talk about Signatera, because that's really new, Dr. Ptak.
Yeah, so in a case where we're so circulating tumor DNA is what we're talking about here. This is DNA that has come out of cancer cells that are just normally turning over. If it's detectable on the blood, that means that there's active disease somewhere. So this test is being used in two ways. One, in a post-surgical setting where the pathology reveals you have very good margins, everything was removed, the lymph nodes were either the ones that were involved were removed or there aren't any involved. Do I need to do chemo? Maybe the oncotype and the mammoprint come back inconclusive, or you're still feeling off about doing that. Maybe you've had a loved one go through chemotherapy and just in your heart, mind, and soul, it doesn't feel like the right option. One option that they're starting to adopt, and it's slow, but it's happening, is to check the circulating tumor DNA, which would only be present if there was residual disease, something that imaging wouldn't be able to pick up on. And in that case, that would indicate that there's residual disease and you'll need some more therapy to make that go negative. So sometimes it's being used in the post-surgical setting to say, do I need adjuvant or post-surgery treatment? Or how aggressive does it need to be? Or can I go into the preventative, treating the root cause approach that we like to add to your plan? The other way that it's being used is to detect if there's going to be a recurrence. So like I mentioned, the circulating tumor DNA becomes positive in the blood if there's a cluster of cells that are replicating. That can happen months to years even before something becomes visible on a scan, depending on how active or fast growing it is. So since we've adopted it, there have been cases where we've caught patients' cancers returning before something can be visible, and then you have a chance to intervene more aggressively with your nutrition and IVs and supplements wherever needed, however needed, or maybe an immunotherapy that you've done in the past that you stopped. It's time to bring that on board before something comes back. It's been pretty accurate for us so far.
Right. So it's a relatively new test because I had a new patient with breast cancer, and she had not been told to do it. So it's only been approved for breast cancer probably May of this year. So very short period of time. So, and yes, we do it here. Yes, we do.
Mm-hmm.
So
in the last 4 to 6 months.
Yes, so, exactly. Really the last.
But even in that short amount of time, we've caught things.
Yeah. So it's it's new. It's just been approved it was first approved for colon cancer, and now it's been approved for breast cancer. But again, that just happened. So if you have breast cancer and you haven't had it done, it's not unusual to not have had it done yet, because not all doctors are doing it. And a patient said a Signatera test. Yeah.
So it's been around longer, but as far as it being approved,
right,
it's newer.
Exactly.
And then how is that different than circulating tumor cells? So one of the differences is that circulating tumor DNA is only going to be present if there's active residual disease or recurrent disease, whereas circulating tumor cells that may have broken off when there was active disease in the past or currently, those are more in circulation for a long time, and they can be either in tissue or circulating. They can be dormant. Those are what can cause recurrence 20 years later.
Right.
So we want to understand what's happening with both measurements.
Right. Exactly. It's not similar to RGCC because RGC is checking circulating tumor cells. And like Dr. Ptak explained, circulating tumor DNA is different than circulating tumor cell.
So we're getting some questions in the chat here. Should we go into the chat?
Sure.
Okay. So let me go. Okay, let's talk about for breast cancer hormone modulating therapy. So tamoxifen, anastrozole, letrozole, some of those.
Right. So it says, do you have women use anti-hormone therapy? Yes, we do. Again, it depends on the patient, the age. So if you're young, without a doubt, you may need Lupron or tamoxifen, depending, again, on your case. And so we do use it. One of my patients came in today. She's 61 or 2. And she said, oh my gosh, my hands hurt, my knees hurt, my body hurts all over from anastrozole, which is what they call aromatase inhibitor. And she said, I had to stop taking it 2 weeks ago because I feel horrible all over. And so, she said, she goes, my oncologist is not going to be happy, but she goes, I have no quality of life. So I said, well, why don't you see how you do for a month and see how you do, discuss it with your oncologist. And I said, we do have a natural estrogen blocker. And so you can at least do that. So you at least think you're doing something. And so, it's, a case by case basis, because as you know, estrogen is also important for your brain and bones and heart and many functions in your body. So in younger people, I think it's much more dangerous to not do estrogen blockade. And you got to make sure your estrogen metabolism is in the proper direction. And then older women, I think we just have to do a case by case. But the standard of care is if you're ER positive, you will get some form of estrogen blockade
for 5 to 10 years. So. Okay, and then BRCA1 and BRCA2 are very common genetic risk factors for breast and ovarian and reproductive cancers. If someone tests positive, what are your thoughts about prophylactic mastectomy with or without prophylactic hysterectomy?
Right. Well, I'm not for removing your body parts, and for a lot of different reasons. You were designed with all your body parts. And I always tell people genetics is not destiny. So all BRCA1 patients don't develop breast cancer, and or BRCA1 and 2. And so I think a lot of whether you're going to express a gene is based upon how you live in each and every day. And you can go to a doctor that knows about BRCA1 and knows about prevention. So you should partner with a doctor who knows about this, what the risk factors are, and knows how to do a very, very good investigation, do an MTHFR, all kinds of
toxin testing.
Yes.
The things we were talking about at the beginning.
Right.
The risk factors.
There's risk factors because we're all at risk. Cancer is 1 in 2 people. And if you look at the statistics, if you have BRCA1 or 2, I think for BRCA1, it's something like 60% will develop breast cancer, and BRCA2, it's like 65, something like that. So again, there's not a guarantee that you're going to get breast cancer or another cancer. So I think you have to take care of your terrain, take care of your individual, situations that going on, and keep your body parts. That's just my, personal opinion.
Because you can always escalate the treatment. You can't ever get the organs back.
Right.
And there's a lot that we doctors like to think we're so, we know everything, but we just don't. What function does your uterus have when you're postmenopause?
Right.
There's research on cortisol and cholesterol being affected when you have a hysterectomy after menopause. but presumably it wasn't doing anything. So I think there's a lot that we don't know, and approaching things cautiously instead of with fear is important. Right.
And I've had patients come to see me for prevention that are BRCA, and we're preventing cancer. So that's what you do.
And maybe screening more regularly.
Right.
Okay. Okay. Is fenbendazole a good choice for hormone-sensitive breast cancer, and should it be taken with ivermectin, possibly a better route than going through mistletoe treatment?
So there's so for people out there listening, fenbendazole is an old anti-parasitic drug, and there's probably circulating on the internet people using fenbendazole. So there's about 310 drugs that starve cancer in the literature. And so fenbendazole, and the patient mentioned ivermectin here. And so those are both drugs. They're both used for many different, ivermectin is used for just more than cancer. But it is very beneficial for starving cancer. Now, you mentioned, is it a hormone-sensitive breast cancer? I think it can be used for any cancer. And again, you want to do it probably under the supervision of a medical doctor so they can properly follow it instead of just doing things on your own. And there are other drugs. There's a great book called Starving Cancer by
Jane McClellan. How to Starve Cancer.
Right. And so, again, they are very effective. It doesn't replace mistletoe. Okay, mistletoe is something else that works on a completely different level than the starving cancer drugs. So it's not an either or. You could use all three of those, the fenbendazole, the ivermectin, and the mistletoe. But there's other drugs too that starve cancer that you would possibly implement.
Yeah, some of the preliminary data is being collected by the Care Oncology group. They're putting out protocols and helping patients get connected to practitioners that can prescribe these drugs. Okay. Let's see. Coffee enemas and fractionated chemotherapy. Are they okay together?
Yes, absolutely. You just don't do coffee enemas when you do the same day you do chemotherapy. Usually I like to wait 48 hours after you do your session of chemotherapy.
So coffee enemas, for those that may not have learned yet, it's when you infuse into the rectum coffee. And the research shows that it dramatically improves or increases the detoxification of the liver and the gallbladder. One of the mechanisms is glutathione production in the liver. So we don't want to do anything that's too detoxifying at the same time that you're doing chemotherapy. We don't want to interfere with the mechanism, but also, even if you're doing low-dose chemotherapy, it's still chemotherapy. It still can be injurious. So we want to be, mindful and be more supportive during that time frame. Okay. Is it okay to take a break? Oops, I lost it. Is it okay to take a break from chemotherapy if treatments seem to be working, tests are good, or will it allow cancer to come back?
Well, usually you do a prerequisite set of chemotherapy depending on your scans, tumor markers, blood work, and everything. So it's not like you start chemotherapy and then you kind of go, oh, I think I don't need it for a couple of months and then restart it. It's not that kind of thing. So you need to complete your course of chemotherapy. Now, sometimes when patients are receiving fractionated chemotherapy here, we'll do it. You may need, let's say, 12 treatments, and then you might need one every 2 weeks, and then you might need one a month. And then, then we'll stop it. But at some point in time, depending on imaging, blood work, all kinds of things. So it's not the kind of thing you start and stop and then start. You need to complete the necessary courses of chemotherapy.
And I don't think it's necessarily that the break allows the cancer to come back. It's just that you need to keep the pressure on it so that it gets to a minimal amount of disease that your immune system can, and then the other supportive things that you're doing can take over. and then more spread out chemotherapies to scavenge any residual disease and prevent it from recurring can, be more supportive. Okay. Do you think that BEMER and Biocharger are enough to rid the body of mold such as ochratoxin?
No.
I don't think so either. Well, first of all, I have a big thing about you have to have your environment tested. If you are still being exposed to mold, you could do everything under the sun to get rid of the mold toxins, but we're still going to find it in your urine and it's still going to be impacting your health. So patients come to me and they're ready for the protocols. And I'm like, we're not doing anything until you get your home tested, unfortunately, and your place of work, and sometimes your car, your boyfriend's house, wherever you could have been exposed. The BEMER and the Biocharger are working on an energetic level to stimulate the cell's function. One of the cell's functions is to detox and eliminate toxins from it. So that can, increase the circulation and the electricity and the enzyme processes that are happening to eliminate the mold toxins. But the most successful protocols have some kind of binder, whether it's something simple like added fiber in your diet, or to charcoals and clays, to cholestyramine and things like that to bind the toxin and carry out. You need cell membrane support, so phosphatidylcholine is very important. You need increased nutrients to process and package up the toxins to be escorted out the body. Sweating, a lot of mold toxins come out in sweat. Drinking enough water, all those basics, but usually, and then at some point, antifungals.
Yeah, it requires specific therapy for, sometimes we do natural, sometimes we use drugs, sometimes we use a combination. But mold is a very, very important thing to diagnose and successfully treat. And like Dr. Ptak said, you've got to find the source. But relying on BEMER and Biocharger will not be sufficient.
Okay, the next question is, I had radiation on my breast for early stage cancer 17 years ago. What are my odds of developing cancer from the radiation? So I actually did a little bit of a dive into this when I did the cancer conversation a handful of months ago on radiation. In the research, it's really hard to tease these kinds of numbers out, but in the research I was finding, the risk of developing a secondary cancer related to the radiation you received appears to be about 5%. The rate of developing a secondary cancer related to the underlying lifestyle factors is much higher. So I think the more of the emphasis should be placed on, one, treating any side effects you had in the moment, but evaluating all the underlying risk factors. Where did it come from in the first place? Because local radiation might reduce the risk of a local recurrence, but it's not going to reduce the risk very significantly of a distant recurrence or metastasis. So just a piece of the puzzle.
Right. Very important, though.
And when we're doing radiation, we can maybe send out that cancer conversation because I talk about this. Depending on where you're getting the radiation, you have to think about what the susceptible organs are nearby. So on the right side of the chest, we're thinking lung and heart and thyroid and
all of the organs, right?
All the organs, skin. So you have to think strategically about where the radiation's happening too. What was that?
My husband has a PSA of
11. My husband has a PSA of 11 and they want to do a biopsy. We've heard that can make the cancer spread. Should we do a biopsy or are there other ways to detect cancer? The MRI was unclear. So this brings up, I mentioned it earlier in the cancer conversation, the ExoDx test that we have.
Right.
It's, for those that weren't with us at the beginning, it's called ExoDx and we've been using it this year and it's been helpful. It's technically it's validated for PSAs of 2 to 10 for patients that are over 50, and it helps differentiate the possibility that there's a high grade malignancy from a low grade in the prostate. If something was there and it was low grade, a Gleason score of 6, a very respectable strategy in that case is to just watch and survey, where you're doing regular PSAs and then trying to address root causes and underlying factors. If there's evidence that there's going to be high grade, a higher risk of it growing faster or spreading elsewhere in the body, you want to have more conclusive or decisive testing and treatment.
And you can do, there's a liquid biopsy called Oncotrace by RGCC, and it will tell you if it's likely a prostate cancer. And but if the MRI was unclear, that's a good sign.
I'd want to read the MRI.
I'd want to read the MRI. And also, I don't know how old your husband is. So if you're young, we got to be much more proactive. If you're older, then that would be a whole different, situation, because a lot of, all the literature says if you're 65-year-old, 65% of men will have prostate cancer, and you most likely will not die from prostate cancer. At least that's what the most recent, literature says. So, but we are, our philosophy is proactive prevention. And so, but we have a lot of our patients don't do biopsies because of the risk that you just talked about. There is a risk with the biopsy, no matter what. I know they'll tell you there's not, but there is. And, but I would do all the kind of preventive testing first to see where you are and what most likely it is, and see what you can do on your own. Like one of my patients that Dr. Ptak and I see, he came back and said, I have 30% improvement on my MRI just doing what we're doing. And so, so he's going to continue doing that. So I think, and, most of our patients don't have, I know a couple patients that have an MRI that there's not a clear, definite nodule on the prostate. So I would, do these other testing first, but again, I don't know the age.
And then I'd be curious too about the history of the PSAs. This
Right.
is the first time it was tested. I also mentioned earlier, how riding a bike and strenuous exercise,
right,
those kinds of things can influence the PSA. Infection, virus, inflammation, candida.
Right.
Okay, getting ready for second debulking for recurrent ovarian cancer. Any suggestions for optimal pre-op health treatments, therapy, supplements? I'm trying to strengthen my core by doing planks and sit-ups. So this touches on the general pre-operation health we were talking about before, where we want to limit inflammation as much as possible, support the oxygenation of the body, make sure we have the proper nutrients on board for healing. I like to think of just the basic vitamins, vitamin A and vitamin C and vitamin D for providing the nutrition needed to heal the tissue. Having enough protein, because it's an injury to the body, you need protein to heal the tissue and repair the cells. So, getting a good source of that.
And we talked about the IVs and the oxygen and all that. So we're going to take one more question. And so just so everyone knows, we're going to be doing a question and answer once a month. So please write on your notes on your phone questions that you may have and that you may accumulate for the month, because we will be doing these once a month. So once a month, we're going to be doing a topic. And the next topic is going to be the brother of the breast cancer patient, Nightbird. And so that's going to be next week. Is that right, Sydney? Okay. Sydney and our marketing team is here helping us orchestrate this. And so that will be next Tuesday. So I will be with Mitch to talk about all of her experience. She was a young lady that came to us with 3 months. Her oncologist in Vanderbilt gave her 3 months to live. And she came in here in a wheelchair, 83 pounds. And of course, you guys know the rest of the story because she became very news. If you just look up Nightbird on YouTube, you'll see and hear her singing. So, so we love to share our information and knowledge because our mission is to educate, empower, and inspire people to live the best lives possible. We need your help, though, because we need your help. You're already here listening tonight, but we need the world to hear all of this information. So we encourage you to share with your family, your friends, your significant other, your fellow workers, so they can be the best version of themselves and take charge of their health. Because Self-care is the new healthcare.
Agreed. Okay, one more question.
Yeah, if you want to do one.
I was kind of skimming through some of them, and it looks like people had questions about what the circulating tumor cell tests and the circulating tumor DNA tests are that we use. And I'd say that since it's the circulating tumor cell test that we've used for many, many years is RGCC, one that we brought on, and that's helpful, as Dr. Connealy mentioned, in the screening phase and the long-term follow-up phase, and possibly testing natural and chemotherapy substances that might have differences in effectiveness. This year we brought online Cell Search by Manarini Labs, and their research it's only limited to 3 different types of cancers at this time, but their research is being used to indicate prognosis in response to treatment. So if there's active aggressive disease, you'll have positive circulating tumor cells according to their, methodology for isolating and quantifying them. And the prognosis is good. Even if there's active cancer, it might not be shedding very many cells. If the results are 0, the prognosis is much more favorable, and you don't have to, the risk of recurrence is lower. As far as circulating tumor DNA testing goes, we're still using many different companies. Since it's newer technology, we're using multiple companies for each patient so that we get a full picture and we make sure we don't miss anything. And so the ones we're using most commonly are Signatera, Guardant is another one. We've worked with Fulgent. We've worked with Caris. So there's a lot of them out there. Foundation one's another one. Tempus is another one. But I've been really pleased with the results we've been getting from Signatera, Fulgent, and Guardant.
Right.
Okay.
Well,
it's wonderful to be with you all.
Yeah, and thank you for being a part of our journey, and thank you for being so interested in what we do. And make sure you share the news and the information all over the world.